Welcome to the Vet Dental Show. I'm Brett Beckman. I'm a board certified veterinary dentist, and we come to you every week on Wednesday to provide the veterinarian and the technician team some actionable things that you can use in your practice. And this episode is going to be a recorded episode that we've done in the past, not a podcast that we've recorded or not the Vet Dental Show, but actually some other information for you that we know you're going to enjoy. So sit back, enjoy, and we'll see you at the end of the podcast.
Alrighty, from Katie. What's the best way to keep patients from becoming hypothermic? Again, that's a good question, and I'll talk about that once we do our anesthesia. But our patients, we have to remember a lot of these patients are smaller and we're getting them wet, like she mentions in here. The other thing we have to remember is they're breathing in cold oxygen, and that can certainly drop their temperature as well. We really want to be diligent about how we are keeping these patients warm. So a couple of things to keep in mind. One of the best ways is delivering warm fluids, and there are fluid warmers available. We don't use one. I just have a little trick of taking the IV line and putting it between the patient and the hot water circulating blanket, which is on the bottom. That's what the patient is resting on. And then in order to cover that 85% of body surface, in order to have good, effective thermal support, 85% of that body surface needs to be covered. We have a bear hugger on top. So just having the hot water blanket on the bottom and then just a towel covering the patient typically is not enough. You need to have that heat source surrounding that patient. So my patients are covered pretty much up to their neck. Feet are tucked in, and a lot of folks will put booties on. Very good idea as well. But keeping that patient surrounded with that 85% of body surface covered, as well as delivering warm IV fluids, those are probably the two most effective things that you can do to maintain the temperature. And we do have a number of small patients, cats, small dogs, that are under for 2 to 3 hours for those advanced perio cases, stomatitis cases, that very rarely go below that 99 mark, which is really nice. Again, that lends them to a nice, quick recovery. When they get hypothermic, their recovery tends to be very slow. And so we want to make sure that we're maintaining these patients appropriately. So those two tips will make a big difference. From Jenna, do we stage full mouth extractions? In most cases, we do not. We are able to, Dr. Beckman is able to do full mouth extractions typically 2.5, 3 hours. And again, we're looking at all of our parameters. We're evaluating how that patient is doing under anesthesia. We're looking at the blood pressure. We're looking at how the temperature is maintaining. And so we'll move forward. If we have those patients that they're under for a long time and now maybe the temperature is starting to approach the little lower portion where we're approaching that 97 mark and we're just not able to get that up, I'm going to evaluate, find out where we are in that procedure. If we're almost done, let's just move on and get them done and get them up and out of anesthesia to get them warmed up. If we're not halfway through with that procedure and the temperature is dropping and we're not able to get it up, then we're aborting. We're going to recover that patient and have him come back and be more proactive. Maybe they were just too deep under anesthesia. There could be a lot of factors why that temperature dropped, but we're going to evaluate and see if we need to abort. But 98.7% of the time, we do not need to stage these patients. And we've had patients that were under the longest anesthetic patient we've ever had was just this year, and it was a corgi that had all malformed teeth that were non-vital, and several were unerupted. That procedure was just shy of 5 hours, and that corgi was up and walking and running to the client, to the the pet parent. And we kept that one about an hour and a half, 2 hours post-op and recovered very nicely. Again, we're monitoring and looking at those parameters to dictate how long that patient can be under anesthesia. From Amber, while in recovery, do you offer the pet food prior to being sent home? We don't, only because, again, my patients typically are awake and ready to go home within about an hour after we're done. And so I'm discharging patients throughout the day. I may discharge patients as early as 10:30, 11 in the morning if we have those repeat patients that are coming in for a 6-month prophy or a 4-month prophy. And they're going home pretty early in the day. So we don't need to feed them in our practice because they're going to be home within a little while after. For those patients that are with us and we don't get to till later in the day, again, they're still going to go home and still, in most cases, be able to eat dinner that night. So we typically don't, only those patients that stay overnight with us do we give food to. From Jacqueline, should pain meds and antibiotics be sent home after extractions, or would it depend on the patient? No, that's going to depend on absolutely pain medication. Antibiotics we talked about. In most cases, no, because we're clearing all of that. But pain medication, absolutely, and depending on what procedure we did. All right, our anesthetic plane, we've got lots of questions here. And do we keep the patients light on anesthesia even during major extractions? Yeah, we absolutely do. Again, we are able to maintain these patients typically 1.5% because we've put nerve blocks on board. And again, we just need them asleep enough, just enough to tolerate the tube. And in a lot of these cases, when Dr. Beckman finishes oral surgery on one side and we flip that patient, they paddle a little bit, and we've got to ventilate a couple of times to get them back down to appropriate plane to continue with oral surgery. But that's how we like them. That's how light we like them. And our nerve blocks do a really good job of allowing us to do that. As far as your question, Nancy, as far as the CRI of the efaxalin, we do not need to do that at all. We can maintain them with just our gas inhalant. Sammy, I love this question. How do you feel about a CVT helping with the dental oral exam charting, or do you feel this should only be done by DVM? I am absolutely on board, as is Dr. Beckman, with a CVT, RVT, LVT, starting that dental chart. That's absolutely in the technician's wheelhouse. And it behooves you to be able to recognize very obvious pathology when looking at the x-rays. So typically what happens is once I complete the x-rays, I can see where we've got significant periodontal changes, bone loss primarily, where we're going to be doing most likely extractions, and I'm already putting my nerve blocks on board in those quadrants. My next step is to grab the chart, go over to my computer, and start putting that dental chart together. Because I can recognize teeth that obviously are going to be extracted, as most technicians can who have seen dental x-rays. I can recognize tooth resorption that I know is going to be an extraction. And so those kinds of obvious pathology are the things that I'm marking, as well as circling the missing teeth, anything that's unerupted, all of that I'm going to mark. And then Dr. Beckman is going to come in behind me and confirm all of that. And then I'm looking in the mouth for gross pathology as well, because I can recognize oral masses, fractured teeth, discolored teeth, tissue that's not supposed to be there, tissue that doesn't look normal, ulcers in the mucosa, all of that kind of pathology. You guys should absolutely be able to recognize and make yourself a very integral part of that dental team in moving that case forward, because sometimes in a general practice especially, your veterinarian isn't available. Maybe they're finishing up a spay. Maybe they're talking to a client in a room. Maybe they're finishing up a phone call. And so anything that you can do to move that case forward is absolutely within your skill set as a good, effective dental technician. So we absolutely, and when I teach my students, we talk about charting, we talk about pathology, radiographically as well as grossly, to set you guys up for success in being that integral part of that team and being able to do that. Kudos to you for asking that question, and I'm hoping that you're doing that already, and that's a huge asset to the dental team. Do we recommend trazodone? Yep, talked about that, absolutely. For those more anxious or difficult patients, anything that we can do to relieve anxiety. And as a tangent to that as well, a lot of times we will have those patients stay with their owners until we're ready for induction. They tend to be less anxious. So if there's a exam room, or if we're still doing curbside, if they want to wait in the car. And when I book those appointments and those owners tell me, hey, he's really an anxious dog and terrible separation anxiety, then those guys stay with their pet parents, and we will try and do them earlier in the schedule if we can. But I let them know that we would love to have them stay with you as long as possible and then get them back to you as quickly as possible in recovery. So we offer that, just thinking outside the box, again, making this as pleasant as possible and exceeding expectations to get much better client compliance with these patients. Will an opiate as part of pre-med be acceptable for just prophylaxis? From Brittany, I can't imagine it would be detrimental if not getting any extractions. Here's the deal. We don't know because we haven't done the assessment. We can't do the assessment until they're under anesthesia. We assume everyone has some degree of disease and will need some form of treatment. Even if it's as simple as root planing, they're still going to need some pain management. Very rarely do we have patients come in that we do not find some degree of pathology. It happens. In our practice, doing nothing but dentistry, it's probably happened maybe 4 or 5 times in the last year. We typically will find stuff. So we assume everybody has some degree of disease, and so our pre-med, across the board, we don't know that it's just a prophylaxis because we are doing an assessment on every patient. For those patients that are coming back for a 4-month or 6 months prophy, a lot of times we're doing root planing, either open or closed. We're cleaning below that gum line. And so they're going to feel that. It's minor, but we still want them to be comfortable on recovery. So we're definitely still going to stick with that protocol, regardless of what they're coming in for. Because a lot of times, if we assume it's just a prophylaxis, we typically will find other stuff. Question from CeeLo on a young pet only needing scaling and polishing. We tend to use Tilazol. Again, my question is, how do we know? At the pre-med portion, we haven't taken x-rays yet. And Tilazol, not my favorite. Again, too much sedation because of that slow recovery. We want these patients up and out of anesthesia and going home, wagging their tail and not out of it for better client compliance so that we can get these patients treated appropriately and as often as they need to under anesthesia.
I trust you enjoyed that episode. We enjoyed providing it. So take care. We'll see you next week.